So good morning to everybody. I have to out myself as another fan of continent urinary diversion, and this is the only disclosure I have with respect to this presentation. Continent urinary diversion was one of the major advances in urology in the 80s and 90s, and Fiona has nicely shown you the evolution of the ileal neobladder. But at the same time, excellent technique for pouches with continent stoma have been developed, and also for continent low pressure anal reservoirs. These were modifications of the oldest form of urinary diversion, the ureterosigmoidostomy. All these techniques had one thing in common: the disruption of the peristalsis, the creation of a spheric reservoir with a high capacity and a low pressure. All these techniques gained great popularity during the following years. However, already in 2009, for the United States, Lavrens showed a decline of continent urinary diversion at a tertiary center, from 47% in 2000 to 21% in 2004. However, looking to NHS data, there was a significant increase from 2001 to 2008, and a decrease thereafter from 2008 to 2012. Here are the data for Germany. We have seen a decrease from 37% in 2006 to 29% in 2014. So the aim of the study I would like to present to you was to test the hypothesis that the declining trend of continent urinary diversion is continuing on a nationwide level in Germany. So we investigated the data set from 2005 to 2022 of the German Federal Statistical Office. And this is 100% of bill procedures in Germany. As core variables, we investigated age, gender, annual count of procedure in each federal state. And our focus was on urinary diversion used in adults based on the OPS codes. And here you can see what we used for data and statistical analysis. So what we found that there was 157,970 urinary diversion during that time period performed in Germany. 28% continent diversion, 72% incontinent diversion. There was an increase of urinary diversion from 2005 to 2016, and a slight decrease thereafter to 2021. Now here you see the figures. The green are the continent diversions, the red the incontinent diversions. Down you have the pouches with the continent stoma, the neobladders, and then the anal reservoirs. This is ureterocutaneostomy, and this is the ileal conduit. What we could see is there is an overall decrease in continent urinary diversion over that time period from 37% to 20%. Let's look a little bit closer to the data stratified by gender and age group. The blue curves are the males. The upper blue curve is the younger male group. The green curves are the females. The upper green curve are the younger females. So what we could see is there is a constant decrease across all age groups for both gender. So there is no argument that we see more older patients and thus we have more incontinent diversions. So for men, the overall decrease was from 42% to 22%, and for the women from 28% to 16%. When we look to the age groups, and these are the younger males, there was a decrease from 56% to 36%. And for the older men, over 70 years of age, from 24% to 10%. Concerning the women, the decrease for the younger age group was 39% to 26%. And that really shocked me that in the year 21, only 26% of females younger than 69 years of age received a continent urinary diversion. For the older females, the drop was from 12 to 6%. Now, in the following, I would like to discuss some possible reasons for these trends and also some arguments that are brought up of those surgeons in favor of incontinent urinary diversion. If many cystectomies are performed at low volume centers, these surgeons are not trained with different types of urinary diversion. Thus, they mainly offer the most simple techniques. And as a consequence thereof, also if these are training centers, the next generation is not trained to perform continent diversion. Some of the surgeons in favor of incontinent diversion argue the high complication rate of continent urinary diversion. We touched that already during the critique panel. But is this really true? And what is also brought up as an argument is the imperfect continence after continent diversion, and especially in female, the high need for CIC. What is the impact of the robot? The learning curve, OR time, the compromises about the reservoir may lead to adverse continence. And what is also claimed is that quality of life is the same after continent and incontinent urinary diversion. But is this really true? So let's start with the number of cystectomies that are performed. And this is a little bit an older study from the US, where you see that the median hospital volume is 12.3 cases per year. 33% by surgeons with an average annual volume of less than 2 cases, and 53% with an average volume less than 5 cases. And there are some recent data that confirm that there was not much change. So you see that 1 to 2 cystectomies are performed by 903 faculties in the US, and more than 12 cystectomies per year are only performed by 551 faculties per year. And we know that postoperative mortality after cystectomy is significantly inversely associated with high volume providers. And I believe this is also true for urinary diversion. These are the data for Germany. At an average, 20 cystectomies per year are performed in a urology department. 88 departments perform over 30 cystectomies a year, or 50% of all cystectomies. And in the year 2017, 29% of continent urinary diversions were performed. So is there a higher percentage of continent diversion associated with high volume centers? Is there a trend that more low volume centers perform cystectomy? We don't know, but this is one of the aims of our ongoing research on the German data. So we already touched this issue, higher complication rate after continent urinary diversion, and there are recent studies that show that if you use high reported standards, that means the DINDO classification and the CCI, then you have comparable morbidity and early complications. And what I already mentioned, the only thing that differs is the complication itself. And these are our own data. And you see that more infectious complications can be encountered in ileal or colonic conduits, more wound infections in the continent diversions, whereas the ureterocutaneostomy patients showed more cardiac, pulmonary, and bleeding complications. And I already discussed that and mentioned it. Also in a long run, the ileal conduit has complications. I don't want to show and repeat the data that was already showed by Fiona. Continent diversion has significant long-term complication, but as you see, the ileal conduit has it too. So this is a study on 412 patients with a long-term follow-up of 98 months. And a total of 66% of complications have been encountered. And you see that there is an increase of complication with time. So you may see that with a follow-up of over 15 years, almost all of these patients will experience a complication. And this is one of the reasons why we don't do ileal conduits in children anymore. Imperfect continence, we already touched that too, and there was a nice publication. It was a comment of Richard Hautmann, another pioneer of orthotopic ileal neobladders. And what he described was that he, as a high volume center, had excellent outcomes with a daytime continence of 95.9% and a nighttime continence of 75.9%. However, others have reported minor outcomes. And he discussed that either continence was differently defined, but what we also touched and what also was underlined by Fiona, it's a different post-op management and rehabilitation, and also the variations in the surgical techniques. What is called an ileal neobladder, according to Hautmann, must not be the same, and I can convince that those revisions I did in Mainz pouches during the last years that came from an outside hospital were a little bit like some of your Republicans' Mainz pouches by name only. So this already we touched neobladders in females. Also the technique of the cystectomy may play a role. And the different shape and volume of the reservoir. What I like to point out that also at high volume centers, other techniques of continent diversion, pouches with a continent stoma, also provide excellent continence rates. So the impact of the robot, it's very difficult to estimate. Because in all the studies, the primary focus was on radicality. Intracorporeal diversion is challenging. There is the learn curve versus caseload we already discussed. The continent urinary diversion is time consuming, and as a result of that, more simple techniques have been used, resulting in worse outcome. And I will show that in a minute. These are the data on cystectomy in Germany. You see the overall decline of open cystectomy, it's the red curve. The total number is the blue one, and at the bottom you see the increase of the laparoscopic and also the Da Vinci assisted cystectomy. So we have seen an increase of robotic assisted radical cystectomy of about 7%, and at the same time a decrease of continent urinary diversion of 17%. Again, back to Richard Hautmann. This is his neobladder, and the shape and the volume of the reservoir are essential for the post-operative continence rates. And now you see the techniques that mainly have been used for robotic neobladders. And we look to the volume. The classical open Hautmann bladder has a volume of 1,085 mils compared to about 200 or 200 cc's of the other techniques. And this is a systematic review of the EROS, European Robotic Group, just recently published on robotic-assisted neobladders. And you see that out of the 2,587 studies, only 19 could be included in this review. 9 different orthotopic neobladder techniques have been used, and the conclusion was major variability concerning complications and outcome. So another argument is that the quality of life for patients after incontinent and continent diversion is the same. So why to choose a continent diversion? And I just would like to give you an overview of the most recent study on quality of life. Brian mentioned yesterday that this is the highest level of evidence. However, a review or a meta-analysis is only as good as the studies that have been included. So when we look to these studies, 18 non-randomized, 29, 10 studies included, 4 non-randomized, 26 included, 4 only women. So, I mean, how you can get a clue out of these different reviews. And when you see what was tested, neobladder versus ileal conduit, this study found a significant advantage of neobladders. Continent versus incontinent, QOL, comparable, may improve. Neobladder versus ileal conduit, significant advantage of the neobladder. Neobladder versus ileal conduit, better quality of life in a conduit, neobladder versus ileal conduit, better global health, physical function, role and social functioning of neobladder, but have more post-op urinary symptoms. And in the women, there was no difference in quality of life. However, I believe it should not be an argument for incontinent urinary diversion, because as I have shown, we have a poor quality of data. We have no randomized study. We have a bias by the indication for the urinary diversion itself. And we have a subgroup analysis which is lacking. A patient who has incontinence after a continent diversion, or a patient who has a problem with the stoma, so that the bag is not fitting very well and he is losing urine several times during the day, they will have a worse quality of life. And I mean, these are things that should be considered when doing a quality of life study. And at least more recent data show an advantage of neobladders, at least in females. So in conclusion, we have a constant decrease of continent diversion in Germany across all age groups for both gender, lower percentage of continent urinary diversions in females. Whether continent urinary diversion is associated with high volume center, we don't know, but as I said, we are just investigating the data further, and I hope I can come back with more detailed data next year. We have a comparable morbidity and early complications of continent and incontinent diversion in studies with high standards of reported data. Also, the ileal conduit has significant long-term complications. Continence rates after continent diversion strongly depend on the technique for cystectomy, the reservoir shape, and also the surgeon's experience. And robotic-assisted surgery seems to have an impact. However, it's not yet proven, and I also hope to get this data out from our ongoing study. And to my opinion, quality of life should not be used as an argument against continent urinary diversion because of the bad quality of data, the bias, and one has to keep in mind that recent data are in favor of continent urinary diversion. So thank you for your attention, and we just published our data in the British Journal of Urology, also with a table included on the recent literature on that subject.